A very good morning, and thank you for this opportunity. Coming to the last topic of today's IC on keratoconus, it's titled as Paradigms, Paradoxes, and Controversies in Contemporary Management of Keratoconus. In this, I'll not be highlighting any specific aspect of keratoconus, but I'll be just going through the various or few among many unanswered questions in the contemporary management of keratoconus. So if you look at the publications in keratoconus, there's a huge surge in the number of publications. When you look at the first part, it's like only 1,754 publications in 100 years, that is till 1999. But in the last 24 years, there's almost 5,000 plus publications. There is one particular conference that is dedicated only for cross-linking, and it's happening for the last 20 years. There's one journal only for keratoconus. So much of research is happening in this field. And definitely there is paradigm shift in all the aspects of the keratoconus management, right from the epidemiology to the surgical management. But still, there is a lot of disagreement among the experts in all the fields of keratoconus management, and we are trying to connect the various dotted lines so that we can give the best possible treatment to the patient with the available knowledge at this time. So, are we really witnessing a true increase in the incidence of keratoconus? We don't know, because the prevalence is, when we were studying, it was 1 in 2,000. Now it has crossed 3.3% in India, and more than that in other countries like Saudi Arabia. It's probably we are picking up more cases. Slides are not fully visible. Can you change? Probably we are picking up more cases because there is a lot of demand for the refractive surgery, and we are doing a lot of refractive surgery screening. Also, there's a possibility that our lifestyle has changed. There's more of pollution, more of allergy, and we are actually making more of keratoconus patients. So all the more we are seeing more of unilateral cases. So there were a lot of case reports coming up. There is unilateral keratoconus, but the paper on the global consensus on keratoconus has clearly stated that it's always a bilateral disease. So what you are seeing as a unilateral disease is nothing but an asymmetrical or presentation, of a bilateral disease where one eye has actually presented a little early than the other eye. So the other eye is always called a forme fruste in such cases and will be considered as a keratoconus even if there is no clinical symptoms in it. When we think of bilateral cases, we have a clue that it may be something related to the genetic. But is there other than genetic, like environmental and the racial, environmental or geographical thing that's happening? That's the clue that we are getting from the example of Saudi Arabia and other countries in the Middle East, where they have a peak of prevalence in that area. Is it due to any environmental cause? So when they studied the prevalence of keratoconus in UK, they found that still the Asians in the UK were having more keratoconus than the actual national average. So that shows there's a two-hit hypothesis where you have a genetic predisposition, and at the same time when you have an environmental thing putting on that, it actually manifests. So among the environmental thing, two main things have come up, that is the ultraviolet rays as well as the eye rubbing. I'm sorry, the orientation of slides are here and there, and total slides are not coming up. The slides, it's not the way I've put it. No, previous slide, please. So the highlights here is on the UV light and the eye rubbing. So UV light, it's actually a paradox. Like UV light we are using for the treatment of corneal cross-linking and for the keratoconus. So how UV light is causing problem? It's causing oxidate stress in the cornea, which in keratoconus predisposed cornea is unable to tackle. So what happens in cross-linking? Cross-linking, what happens is you have a riboflavin which acts as a photosensitizer, and you have riboflavin radicals as well as the oxygen radicals, and two types of photochemical reaction, one aerobic and non-aerobic reaction is happening. So oxygen and riboflavin radicals together are forming the cross-linking. I'll come back to don't look at this slide, please. So the question here is there a true association between atopy and keratoconus. We have been telling like allergy and keratoconus is so much related. But in a large series of study, it has been shown that it is not the allergy that is actually associated, it's the eye rubbing. Yes, allergy is associated, but the strength of association is more for the eye rubbing rather than the atopy itself. So if you can see something in the last part of the slide, the angioedema, urticaria, atopic dermatitis, history of anaphylaxis, these are actually not related to keratoconus. So we have been going with the idea that allergy directly proportional to keratoconus. It's not that. It is actually the eye rubbing that is causing the problem rather than the atopy itself. So we are having keratoconus in non-allergic people also. People who are having, you can, I'm very sorry about the slides, people who are having the habitual eye rubbing, they have been called in this context as chronic habitual abnormal rubbing, CHAR. These are the people whom you can very easily see, like we have a lot of people who are sitting in front of the screen the whole day. They keep doing this when the eyes are tired. They keep rubbing this, which when we ask them, are you an eye rubber? They say, no, I don't rub my eyes. This happens very involuntary and they actually don't know that they are rubbing the eyes. And these are the group of people who are non-allergics but eye rubbers, ultimately ending up in keratoconus. And the eye rubbing, is it just mechanical effect of the eye rubbing or is anything more? It is mechanical as well as inflammatory. So we have come from a non-inflammatory etiology of keratoconus to inflammatory etiology. But we are not seeing any signs of inflammation. It is called pauci-inflammatory. But we are looking the signs of inflammation on cornea. The signs of inflammation is not on the cornea, it's in the ocular surface and the tear film. All the disease markers or the biomarkers of the inflammation is in the tear film and not in the cornea. So again, there are certain confounding factors for that. You have allergy associated with it, you have eye rubbing associated with it, you have dry eyes in such cases. All this can cause inflammation. So we are not sure whatever biomarkers we are seeing in the tear film, is it specific for keratoconus or can we directly relate these biomarkers for keratoconus so that we can use it as a screening tool to identify early keratoconus. Another screening tool which we use is OBSCAN or topography. We normally use at the anterior and the posterior curves, but it has been identified that if you look at the comma aberrations, you can actually identify the keratoconus much early than the changes that happen in the anterior and the posterior curve. But is it anyway important that we do all these preclinical tests to identify the keratoconus? Are we going to treat a preclinical patient? That is the question. Is there any need for screening like what we do in glaucoma? If we identify it, are we going to treat it or we are going to document the progression? We very well know that every ectasia need not be cross-linked. Some of them may not progress at all. And what we say as cross-linking, a paradigm shift in the treatment has its own set of complications and failure rate also. So it cannot be given to all those who have been diagnosed as keratoconus. And we have a unwritten rule or we have a rule that we don't do anything about 35 years or in a patient who is already having 6/6. All these set of complications is very well known and it's up to in the paper publication and is around 3% of complications is already well known. But this is one new complication that is coming up in the keratoconus, like what Dr. Anita Madam told. Patients who have been aggressively cross-linked 10 years, 15 years back are now coming up with progressive thinning of the cornea. At that time, we have reported, we have all presented in the conference cross-linking safe after 1 year, 2 years, 3 years. But now after 10 years, they are coming with these sort of corneas and these have been presenting in conferences now more and more. It's a progressive thinning of post-cross-linked cornea happening many years later. So what could be the cause for it? Going back to the previous slide, we have been telling that we are using oxygen radicals as well as the riboflavin radicals for the cross-linking. It is a possibility that we have been doing the process, but the riboflavin was not actually there in the right concentration. There was more of an oxygen radicals. The riboflavin radical was less. So the oxygen radical alone is going to do more stress for the cornea rather than the cross-linking. Maybe it's just a hypothesis. Somehow the progressive thinning is continuing and we are not getting the actual effect of the cross-linking. So advancing age, we normally don't try to cross-link anyone above 35 or 40. But this is a classical example in which one eye I had cross-linked is good, happy, a little bit of scarring is there, but flattening, it has achieved the flattening, patient is having unaided good vision. The right eye was not cross-linked because of the advanced age, it is actually showing signs of progression, and there was no absolute risk factors which we normally look for. Another case, again, above age of 35, it is progressing. So everything in management of keratoconus is centered about the word progression, but actually speaking, we don't know how to define progression. In this, actually that ABCD classification, we have BCVA as one of the variable, but it is clearly shown that UCVA or BCVA is not required for documenting progression. That is another unanswered question. And mostly we look at the keratometry, and it's just one piece of the puzzle. Others like various Kmax, pachymetry, various indices, everything has been described, but none of them has been validated. So the global consensus, again, this is the one good paper which is talking about the consensus in various management keratoconus. They say consistent change in at least two of the following parameters. Still, they have written only the parameters, not about how much in how much period. Like one diopter in 1 year or nothing like that has been documented. And in this also they say that the BCVA is not a very good predictive factor. That means, in spite keratoconus, your vision may be unstable, it may be changing. Your vision may be stable, but it may be progressing. So it's totally unpredictable because the progression is not linear. It's not like happening every day in the same speed. And the progressing indices are also not validated. Sometimes we see only one eye progresses, and there are the various variables like pachymetry may be reducing, the keratometry may not be having same change in its value. Managing progression after crosslink is an absolutely difficult thing because it cannot be identified at all. Is this a post CXL progression? One eye, good flattening, happy patient. Other eye is actually worsening in the astigmatism after keratoconus. So I have done the C3R, I have induced more astigmatism into the patient. What good did I do to that patient? So how I can assess progression in a post CXL cornea? I cannot actually do it. It is probably remodeling of the corneal filaments, or it may be the effect of the RGP on the topography, or it can be actual failure or the progression, failure of the procedure or the progression. I am left with only one clinical sign to look for any signs of post C3R activity, that is demarcation line. So does this demarcation line actually show the effect of the C3R? It's no study actually proves it, that the demarcation line can I? We have fine time. Yeah. So this doesn't actually tell us that directly that the mechanical properties or the stiffness is related to the demarcation line. So there comes a question of extent of cross-linking. What is the actual extent of cross-linking that is needed on that particular cornea to stop the progression of the cornea? This is not defined. So when you do various accelerated and other this and that newer modalities of C3R, you don't know whether you are achieving the same extent of cross-linking that is actually needed. It is whether it is an all or none thing, or it is partial effect that's happening, or whatever it is. It has not been studied in vivo. We know accelerated protocol based on this Bunsen-Rusko law, but it's only for the photo damage or the photochemical reaction. But it's actually the cross-linkings happening in the same, following that law, it is again unanswered. The difference in the accelerated is that accelerated shows a very shallow demarcation line, which shows that it may not be as effective as a Dresden protocol. There are some studies shows that it's equally effective also. The difference here is the availability of oxygen, which was clearly demonstrated and clearly mentioned in Dr. Anita's previous talk. All these accelerated modalities, accelerated protocols have less oxygen availability because the time exposed is less, up to 9 minutes or 10 minutes or whatever it is. Sometimes we get unpredictable results like this. In the left side, you see the CXL was not done, it didn't progress, vision is maintained. The left side, aggressive CSR was done, CXL was done, it went into scarring, astigmatism, vision dropped, and unpredictable result. So it can induce scarring, it can increase astigmatism, it can cause more thinning, which are all undesirable effects of C3R. Why this is happening? Because the cross-linking which we say, it's not happening at the same level, same extent at all the levels. Some areas are more cross-linked, some areas are less cross-linked. So what we are actually creating a more irregular cornea. And this is not predictable. See, if you look at the top scan, the left, both are the eyes of the same patient, but in one eye we had a very good result, in other eye we have a bad result. We are actually creating more astigmatism in that. It is a remodeling of the collagen as an effect of the cross-linking, but an undesirable, unpredictable remodeling is happening there. So can we predict the remodeling? Customized CXL is one step towards that, where it's a cone-centered approach, or various fluents is used to treat the various areas of ectasia based upon the topography. Again, a very good thought, but we don't know whether it's going to help us or not. Again, combined procedures with corneal cross-linking and the PRK and all we are doing, it's basically to normalize the topography. To bring, you can see that the cone has been brought to the center and it's much more normalized. But again, here the predictability, the refractive stability, and as we discussed in the previous slide, long-term thinning. These are all unanswered questions and now not been studied properly. What if it actually fails? This is a case of actual failure of C3R. After C3R, it went into eye drops. But this is a case of Down syndrome, a child with aggressive rubbing. This is actually failure. We need not look for any investigation to see if it has failed or not. In such cases, we may have to go for surgical management. But in other cases where we suspect failure, there is always a repeat CXL opportunity. It is in literature. Once again, you can repeat based upon various variables like what we have discussed in the previous slides. Pregnancy has already been told. Only one question is, we tell the patient in pregnancy, it may increase. Okay, they are not going to change the plan of pregnancy anyway. It will happen. What are we going to do in addition to that patient? And during pregnancy, okay, we observe. And if it progresses, we again do C3R. So, is it actually risky to do C3R during pregnancy? It's not very documented. One report which I read was that why they don't do C3R is because it doesn't have any effect on the baby or the mother. Probably the results are little unpredictable because of the hormonal changes and the collagen loosening and all those things. Thing is, if it happens to have any complications, we may not be able to do further things for the patient. Unluckily, the patient happened to have a corneal infection, or if she happened to have a therapeutic keratoplasty, probably we may not be able to take up that patient for further treatment. So having that in mind, we tell them not to go for the C3R, and it's not due to any bad effects of the UV rays or anything on the mother or the baby. To summarize, I take this, I borrow this quote from one of the articles, which says that in seeking to determine whether a keratoconus patient is progressing, or remember that we are actually treating patients and not numbers. So what we need is a holistic evaluation that takes into account not just the numeric change in the imaging metrics, but also the patient's history, visual acuity, subjective complaints, corneal signs, is critical to determine whether progression has occurred or not, and is likely to occur in the near future. Because every patient of keratoconus is different, and it's very difficult, I think, in the near future to have a common guidelines to treat all the patients. Thank you very much.
Thank you, Dr. Sujith, for that excellent keynote. Actually, that's very thought-provoking, and I feel a little bit scary in the next days. to deal with the keratoconus patients. Thank